Thank you, Dr. Vipul, Dr. Dhruvi, for inviting me. So, my topic is infections in diabetes. Basically, it's a very vast topic. So, in a small span of time, I would like to cover as much as possible. So, International Diabetic Federation reveals statistic that India has the highest number of diabetic in the world, around more than 200 million. In few years, it will reach around 80% of the world's population. So, we'll talk about infection in diabetes. Studies comparing diabetics with non-diabetics reveals that about 46% of the diabetes versus 38% non-diabetic had at least one hospitalization or OP visit for the infection. The risk ratio for ID-related hospitalization was 2.17 and 1.92 for death attributable to infection. So, what are the host factors? Why are the diabetic population are more prone to the infection? So some are the host factors. So first is hyperglycemia related impairment of the immune response. Second is vascular insufficiency. Third is sensory peripheral neuropathy. Fourth is autonomic neuropathy. And fifth is skin and mucosal colonization with pathogen such as staph and candida species. So I would like to go through hyperglycemia related impairment of immune response. What happened when there is hyperglycemia? The neutrophil chemotaxis and adherence to vascular endothelium, the phagocytosis activity of the neutrophils, the intracellular bactericidal activity, all are impaired with the diabetic population and hyperglycemia also. So for vascular insufficiency, vascular disease is common in diabetic. As you know, when present, vascular insufficiency may result in local tissue ischemia, which depresses oxygen-dependent bactericidal function of leukocyte. And also, vascular disease related to diabetes also impair the local inflammatory response and absorption of antibiotic, which hinders the healing of infection. Next point, the sensory peripheral neuropathy. Even minor local trauma in patients with diabetes-associated peripheral neuropathy may result in skin ulcers, which in turn leads to diabetic foot infection. Skin lesions in such patients are often either unnoticed or ignored until infection occurs. Autonomic neuropathy. Patients with diabetic are associated with autonomic neuropathy may develop urinary retention, which is the main cause for developing UTI in diabetic population. Increased skin and mucosal colonization. So patients with diabetes who inject insulin daily have often asymptomatic nasal and skin colonization with Staph aureus. Colonization may predispose to cutaneous or incisional staphylococcus infection as well as transient bacteremia, which may then result in infection in distant sites such as damaged muscle. So these are some common infections in the diabetes. This side, you will see that these are the common infection in diabetes, and on the left side, it is the infections which are exclusively seen in diabetes. So what are the common infections in diabetes? Pneumonias and tuberculosis, pyelonephritis, cystitis, perinephric abscesses, soft tissue infection, necrotizing fasciitis, and mucocutaneous candidiasis. And what are the other infections which are exclusively seen in diabetic? Malignant otitis externa, rhinocerebral mucormycosis, and emphysematous cholecystitis and pyelonephritis. So I would like to go in each of the infection in detail. The first is rhinocerebral mucormycosis. As everybody has seen during COVID times, increases use of systemic steroid, which causes hyperglycemia, and we have seen like in lakhs and lakhs patients of mucormycosis during the COVID period. So what is mucormycosis? It is a fungal infection caused by the mucor species. So these are the species Mucor rhizophus absidia, but the most common is mucor species, generally seen in diabetic ketoacidosis. What are the symptoms? Symptoms are the neurological deficit such as proptosis, visual loss, ophthalmoplegia, cranial nerve palsy can occur. How it invades? It invades into paranasal sinuses. It goes to sphenoid, ethmoid, other sinuses, floor of the orbit, skull base, and also can inwards into brain parenchyma. So how can we diagnose this mucormycosis? By CT or MRI would help. Sure, biopsy, it is important. Biopsy scraping or discharge stain with KOH pass or GMS stain shows broad aseptate branching hyphae. It is the main feature for mucormycosis. You can see this aseptate branching hyphae. You will see septate branching hyphae in aspergillus-like infection. Okay. Fungal culture, it never grows. In my life, I haven't seen any mucor is grown. I don't know why. But it is diagnosed by KOH stain, PAS stain, and GMS stain. So what is the treatment for mucor? The main treatment is surgical debridement. Once, twice, thrice, multiple debridement may be necessary. And with antifungals. So antifungals, what options is available nowadays? The mainstay of treatment for mucormycosis is liposomal amphotericin B, 5 to 10 milligram per kg per day. Also, we can use conventional amphotericin B, 1 to 1.5 milligram per kg per day. But nowadays, it is like nobody is using it due to its nephrotoxicity and due to hypokalemia situation. The second is isavuconazole, 200 milligram daily can be used. It is an alternative therapy. In international guidelines, they have also said that you can use as a primary treatment also. But in India, I don't know. Third is posaconazole, 300 milligram OD can be used as a salvage therapy. Not a main treatment, but after finishing your liposomal amphotericin for 6 weeks, 8 weeks, you can give posaconazole. Now the cure depends on the site of infection, clinical and radiological resolution. Mortality is more than 30%. Now, I would like to go to second. Invasive otitis externa. So 90% of the patients are diabetic. What are the risk factors? Poor glycemic control, old age, hearing aid use, ear irrigation with unsterile water. These are the risk factors. Most common organism causing malignant otitis externa is Pseudomonas. About more than 90% cases, Pseudomonas is the culprit organism. What are the features? Persistent ear discharge, ear pain, and radiological evidence of erosion of ear canal. So, in such cases, early involvement of ID and keeping low threshold for imaging will save from lot of mortality and morbidity. So, how we can diagnose malignant otitis externa? Yes, imaging, MRI, CT with contrast would help. Intracranial extension into temporal bone with involvement of facial nerve, TM joint, mastoid hair cells, base of skull, sigmoid sinuses or the meninges can occur. What is the management? Yes, surgical debridement is the first treatment. Second, detailed microbiological workup. Before starting any antibiotic, please send cultures. Every time, if you suspect any infection in the body, please send cultures. It can be a tissue, blood sample, urine sample, sputum sample. But before starting any empirical antibiotic, in any infection, please send regular cultures. Also, histopath can diagnose malignant otitis externa. And main treatment is debridement with followed by antimicrobial therapy. So, broad spectrum antibiotic would help in such cases because the Pseudomonas is culprit organism. And about 4 to 6 weeks of injectable antibiotic followed by oral may help. The next is pulmonary infection in diabetes. Yes, increased frequency is seen in diabetic population with Staph aureus, GNB organism, and Mycobacterium tuberculosis infection. Diabetics with pneumococcal pneumonia are more likely to develop bacteremia and have significant higher mortality. Treatment regimens remain same that for non-diabetic there is no other indication. So what is the recommendation? Pneumococcal vaccination should be given. Annual and other annually inactivated influenza quadrivalent vaccination should also be offered to diabetic population. Now tuberculosis and diabetes. Yes, there is significant association between diabetes and acute tuberculosis. Relative risk of developing active disease is 2 to 4 times that of general population. An increase in dose of sulfonylureas may be needed if rifampicin is co-administered. This is for diabetologists. Duration of treatment, bacteriological conversion and relapse rates or everything are same as non-diabetic. Diabetic with HIV and co-infected with tuberculosis needs special precaution, expert supervision and ID opinion. Now urinary tract infection. What is asymptomatic bacteriuria? Asymptomatic bacteriuria is defined as more than 10:5 colony forming unit of organism in urine without any symptoms. It is 3 times more common in diabetic population than non-diabetic population. Hence, I would like to emphasize, no need of antibiotic for asymptomatic bacteriuria. Now, I would like to ask a question to the audience. A 35-year-old female, pregnant lady, third trimester, his urine routine suggests you of around 150 to 200 per cells. Urine culture suggests you of E. coli growth. Will you treat or not? Treat, yes. So there are 3 conditions where you need to treat asymptomatic bacteriuria. The first is pregnancy, second is urogenital procedure, and third is renal transplant or any other transplant you need to treat. Symptomatic bacteriuria, cystitis and pyelonephritis. Cystitis is lower UTI presented with, can be presented with dysuria, frequency, suprapubic pain, high incidence of unsuspected upper UTI, hence treatment for 7 to 14 days is needed in diabetic. Rarely emphysematous cystitis can occur. What are the symptoms of emphysematous cystitis? Hematuria, pneumoturia, and chronic abdominal pain. Pyelonephritis is more common 4 to 5 times in diabetic population than non-diabetic population. In diabetic population, it always presents with bilateral pyelonephritis. What are the symptoms? Fever with chills, flank pain. How will you diagnose? Imaging, USG, CT IVP, urine culture. Send urine culture before starting any antibiotic. If the symptoms does not subside on the 5th day, search for other complications such as renal or perinephric abscesses, emphysematous pyelonephritis, or renal papillary necrosis. Emphysematous pyelonephritis. It is 70 to 80% seen in diabetic population. The severe acute multifocal nephritis. E. coli is the most common organism, followed by Enterobacter, Klebsiella, Protease, Streptococcus, and Candida also can cause emphysematous pyelonephritis. What are the risk factors? Women, obstructive uropathy, like stones, strictures, are the risk factors. What are the clinical presentation? Flank pain, crepitus in the abdomen or thigh. What you will see in the X-ray is a gas about in 85% of the patient. CT scan is the test of choice. Mortality is more than 60 to 80% with only conservative treatment. So such patients should undergo nephrectomy when indicated. Next is emphysematous cholecystitis. Uncommon, not common is emphysematous pyelonephritis, but yes, we have seen uncommon and serious biliary infection. Risk factors are diabetic, male, gallbladder surgery during active biliary infection, gallstones, abdominal crepitus may be present, polymicrobial, gram-negative organism, it can be anaerobe also. Mortality is around 15 to 25%, and the treatment is surgical with broad-spectrum antibiotic. Other enteric pathogens which are associated with diabetic. Diabetic often causes autonomic neuropathy, hence dysmotility syndrome, such as esophageal, gastric, and colonic dysmotility syndrome, which increases chances of salmonella enteritis 3 times more in diabetic. Campylobacter 4 times higher. Listeriosis acquired through GI tract, which causes higher mortality in diabetic. So, skin and soft tissue infection. More skin and soft tissue infections occur in diabetic population than non-diabetic. Sensory neuropathy, atherosclerotic vascular disease, and hyperglycemia all predispose to soft and skin tissue infection. Blood glucose level more than 250 is a risk factor. Other risk factor includes dry skin, cellulitis, edema, peripheral vascular disease, and tinea. This is intertrigo seen in diabetic population. Most common it is fungal. Treatment with antifungal, oral or local application can be done. Pyomyositis, again most seen in diabetic population. It is the infection of the muscle, collection over the muscle. Most common organism is Staph aureus. Also Streptococcus can cause pyomyositis. The treatment is surgical drainage and antibiotic. Yes, synergistic necrotizing cellulitis. It is seen in diabetic. Necrotizing fasciitis, involvement of underlying muscle. Skin, muscle, fat, fascia are infiltrated. Usually involves perineum and lower limb. Presence with severely painful soft tissue with necrosis and ulcer, draining discolored foul smelling fluid. Most common gram-negative and anaerobes are the culprit organism. Surgical debridement with broad spectrum antibiotic may be needed as soon as possible. So next is Fournier's gangrene. About 40 to 60% of Fournier's gangrene person are diabetic. Predisposing factors, other genitourinary and colorectal pathologies may be associated. Symptoms, scrotal discomfort, erythema, edema, skin necrosis can seen. Polymicrobial. So the treatment is surgical debridement with immediate broad spectrum antibiotic. Don't wait in such cases, please. Diabetic foot infection, I won't go detail because there is a session in the afternoon. Yes, melioidosis. Melioidosis, again, it occurs in the diabetic population more in diabetic population. So what is melioidosis? Is it an infection caused by facultative intracellular gram-negative organism, Burkholderia pseudomyeli? It is spread by inhalation, percutaneous inoculation. What are the risk factors? Diabetic, alcohol, chronic renal failure, CLD, thalassemias, malignancy. About 88% it is acute presentation and about 12% it is chronic presentation. You can see this is the cutaneous melioidosis. Second is melioid pneumonia. This is melioid pneumonia. This is melioid liver abscess and this is melioid osteomyelitis. So it can affect any system of the body. So what is the treatment for melioidosis? The treatment is ceftazidime, 2 gram every 6 hourly for initial intensive phase. In critically ill patient, if the patient is in ICU, patient is in septic shock, please start meropenem. You can go up to 2 gram TDS according to the body weight. In eradication phase, TMP SMX can be used, even doxycycline can be used. HIV and diabetes, it is a very important topic. Two distinct conditions, but they can interact in a complex way, mainly in type 2 diabetes. Many antiretroviral therapy can cause insulin resistance, fat redistribution, lipodystrophy, increased cholesterol and triglyceride, like zidovudine, lamivudine. Even this metabolic changes increase the risk of developing type 2 diabetes. HIV, control or uncontrolled, causes low grade of inflammation, which again causes insulin resistance.
Sir,
Poorly controlled diabetes can weaken immune system, increases ill effect of HIV. So HIV and diabetes comorbidities make infection management more difficult.
Sir, please conclude.
Yes, this is the last slide. So my take-home message, people with diabetes are more prone to infection due to impaired immune function, poor circulation. Infections may be more severe, frequent, and slower to heal in diabetic population. Good glycemic control, regular monitoring, foot care, timely vaccinations are essential preventive strategies. Always maintain a high index of suspicion. Even minor symptoms can indicate underlying serious infection. And last, early involvement of ID physician and appropriate investigation can treat in time and save lives. Thank you.
So thank you very much for your